Hello, my name is Matthew Ricks and I'm going to discuss with you today ulnar column and complex injuries to the wrist and how to manage them. We're going to cover an element of normal anatomy, address some classifications, and then identifying these injuries and going through some management plans for them. So ulnar column injuries are important injuries to recognise. They've been well known about for a long period of time. We know the distal radial ulnar joint articulation is between the ulnar head and the sigmoid notch. We know the sigmoid notch is a shallow concavity found along the ulnar border of the distal radius. It's most stable in supination according to the literature. The TFCC is an important component of your distal radial ulnar joint stabilization. It attaches to the fovea at the base of the ulnar styloid. This is why you commonly see your ulnar styloid avulsion fractures. It has components which include a central articular disc, a meniscus, and then there's volar and dorsal radial ulnar ligaments, as well as ulnar lunate and ulnar triquetral ligament origins. And there's a flaw of the ECU tendon sheath. So multiple factors make up this ulnar side of the wrist and the potential of injuries with associated distal radius fractures all on their own. The ulnar styloid fractures we tend to commonly see. So when I address my distal radius fracture, if there's an associated ulnar styloid fracture, I will assess the drudge to assess the stability in both an AP and lateral radiograph. And if I'm concerned, then I can get a live X-ray streaming to see if I need to assess the stability. There's options available to your distal radial ulnar joint if it's not stable, and these can either include Kwire temporary fixation and then removal, or even ligament repairs open to your drudge ligaments. In the situation of a base of ulnar styloid fracture, you can consider tension band wiring with a footprint anchor as demonstrating this X-ray is one option if you think that that's contributing to the instability element of the distal radial ulnar joint. Ulnar neck fractures distal radius can be a little bit more difficult to manage. This is an example of one patient of mine who fell into outstretched hand, no osteoporosis, and sustained this distal radial and distal ulnar fracture. Now, a couple of points you can note is that the degree of comminution to that distal ulnar and distal radius is quite high. And if you look on the lateral, you can see that there's going to be an area potentially of a bone deficit or at least high comminution and fragmentation to those fractures. So there's a couple of concerns that I have for this. In this type of patient, we actually got a CT scan to assess the amount of bone distally to allow me to plan my fixation, not only of the radius, but also of the ulnar as well. So I was assessing the quality of the bone, assess which fixation is based for this patient. So in this situation, we took her to theatre. We opened up only first. We got an ulnar plate on. We reduced it back out to length. So there were some fragments noted on the CT scan, particularly medially to the ulnar, when the radius itself had a large degree of comminution to that metaphyseal area. So I used the ulnar to help get my length correct. I realized preoperatively that there should be a good enough amount of bone to the distal ulnar to allow me to get some good screw configuration in. And in this case, we got it out to the correct length, got a locking screw configuration both distally and proximally, and managed to hold it out to length and in a good position. I then proceeded to go on to my distal radius fixation through the modified Ulnar approach to the wrist. If there were concerns of my ulnar fixation, if it cuts out, if the bone was very poor intraoperatively, and there's other options that you can consider. One of those is obviously fixing the distal radius and leaving the distal ulnar, however you have an unstable element to it. One of those could be a bridging plate placed across from the radius to the metacarpal as well. There are options available to us, but with this type of patient, we had a good enough bone stock distally, allowing us to use a plate and screw configuration to hold it into position. Sometimes you have such a comminuted distal radius as in this case that we had, and the background of known osteoporosis. Now there's a couple of factors on here. One, you're struggling to make out the articular surface. It's significantly comminuted, and there's a degree of radial deviation that you can see there. So a couple of factors in that original X-ray which are making me concerned about the quality of the bone. We pull it out to length, and you can again see the degree of fragmentation you have to the articular surface, and the concern of the poor quality of bone that the patient's going to have. Now, my worry is that they're unlikely to tolerate an X-fix. They're going to have very poor quality bone. There's going to be the pin sites coming through, which potentially introduce infection and may murky the water for any defensive operation coming down the line. But I think in this case, there was a CT scan that was performed, confirmed the degree of comminution, and the X-fix was placed on by another hospital, but then came to us when there were issues with the external fixation. They had cut out. So it came to us, and at that point we ended up doing a bridging plate configuration. Personally, I probably would have done a bridging plate configuration right at the start, but it's difficult to say with these patient groups. I did a dorsal approach and then placed in the bridging plate and removed it at 6 months and started mobilizing the wrist. I think the key point of this case is to highlight that sometimes your distal radius is beyond fixation, and you just need to get that wrist out to length and get it to come to a degree of uniting, and then you can get some movement back when you remove the plate. Obviously down the line there's the option of a fusion of the wrist, but that is a very last case scenario, and I think in this situation you moved the plate and she was happy with the functional return that she got after about 3 months of mobilizing following removal of plate. There are soft tissue complications, distal radius fractures you need to be aware of, the FCC tears, ulnar column injuries, which we've highlighted a few, EPL and FPL ruptures, and nerve issues, particularly carpal tunnel syndrome. Compartment syndrome you need to be worried about, particularly with your high energy comminuted fractures, associated ligament injuries in the wrist, and the chronic regional pain syndrome, which I know we're talking about later on. When to get further X-rays, I think it varies from patient to patient, fracture to fracture. Most of my patients get an X-ray every week, and if they have stable configuration, they're going to get an X-ray 6 weeks and removal of cast. If I feel there's a degree of instability from a fracture configuration, quality of bone, or patient factors, then I follow them up at 1 and then 2 week X-rays with an X-ray of 6 weeks. I think you do have to vary it from patient to patient. Ideally, we want to try and decrease the number of follow-ups, but we also have to watch the ones that have a chance of moving. So what do I KY? KY young patients with good bone, extra-articular or even supraarticular, intra-articular fractures that can be reduced and held with a KY. I think they work very nicely. Open tucks internal fixation, elderly osteoporotic ones. It's an option. Any comminuted displaced fractures, intra-articular fractures that are displaced, and these allow early return to work. And young patients with volar displacement, I think your volar Barton ones particularly need that buttress plate, and the volar plate works very nicely for those. Which ones do I use fragment specific plates? So not just volar and dorsal Bartons. I also use them if I've got a significantly comminuted intra-articular distal radius fracture. So I commonly augment my distal radius volar platings with radial styloid platings as need be, or the lip hook plates that you can get as well. So these fragment specific ones are another weapon in our arsenal when treating these. Spanning plates I tend to use are highly comminuted articular fractures. There is the place for external fixators, but I don't tend to use them anymore. I think open fractures with tissue defects is a very good option of practicing the span, scan and plan, but I do find that most of these fractures occur in elderly osteoporotic patients, and I find they don't tend to tolerate external fixators very well, and the pins have a risk of breaking and cutting through the bone, particularly the osteoporotic bone as well. Thank you very much.